clinical and molecular hepatology, and he served on the editorial board of multiple journals including the Hepatology Communication and Journal of Clinical Gastroenterology. He is the distinguished himself in the field of viral hepatitis, and his particular interest is in the research of hepatitis C. He served as the principal investigator for the multiple seminal trials and have been published in the journals including the New England Journal of Medicine, the Lancet Gastroenterology, Hepatology, and Journal of Hepatology, and many more others. So let me introduce further that Dr. Ko has served on the numerous committees for the AASLD, ASG, and ABIM in addition to other organizations. He has won the multiple awards for his clinical care and teaching, and he believes in the importance of mentoring the college students, medical students, residents, fellows, and faculty in the clinical research. So today he will talk on the management of complex variceal bleeding. Please, sir.
Thank you. And we're just going to spend a few minutes now going through some of the hopefully clinical pearls that will allow you to manage some of these patients who present with variceal bleeding, both the straightforward and then again not so straightforward as well. No disclosures for this. So we've already heard quite a bit today, excellent talks on non-cirrhotic portal hypertension as well as the role of albumin. And so just by way of pathophysiology, all of you know in the cirrhotic state, basically we develop complications two ways, either through portal hypertension, that's certainly how variceal hemorrhage, ascites occurs, and to some degree encephalopathy with the portosystemic shunting. There's also liver insufficiency. The liver just doesn't do what it's supposed to do. This can be such things as breaking down ammonia when it comes to through to the liver, or excreting bilirubin, we get encephalopathy or jaundice. So in the setting of cirrhosis, and in Pakistan here, it's predominantly viral hepatitis followed by non-alcoholic fatty liver disease. The things that decompensate, the episodes of decompensation are most commonly ascites, we've heard this, but also variceal bleeding and hepatocellular carcinoma also occur annually, about 1% for variceal bleeding, 1 to 2, maybe 3% for HCC, depending on what the etiology of the cirrhosis was. But the most common cause of decompensation is ascites, but variceal bleeding is coming up thereafter. And once you decompensate, then you need to be thinking about whether or not this person should be considered appropriately for liver transplantation. Not all of these individuals who come to us are transplant candidates. Some simply have too many comorbidities. We had a very nice talk yesterday about the role of palliative care in assessing these individuals, and that's something that we're going to have to talk about and much more with our patients as the magnitude of the burden of chronic liver disease comes upon us. So we heard a little bit today already about non-cirrhotic portal hypertension, so you're already familiar with the concepts of the various types of portal hypertension that we have. These can be prehepatic, this is the portal vein thrombosis. It can be pre-sinusoidal, that is the portal hypertension and the fibrosis and obstruction is in the is just before the hepatic sinusoid. This is what we see classically with schistosomiasis, but we see it with chronic cholestatic liver disease as well. Cirrhosis is the most common cause of portal hypertension. Veno-occlusive disease in our marrow transplant patients, or some who are so unfortunate to take some complementary alternative medicines, and then finally Budd-Chiari syndrome. Regardless, all of these can lead to variceal bleeding, which you will need to potentially address. Patients come into the hospital, you're called in emergently. So the reason all of this happens is in the setting of cirrhosis is because of the splanchnic vasodilation that occurs in the setting of a fibrotic liver, where the blood flow goes into the liver and you have these shear forces, and the endothelial cells will increase synthesis of nitric oxide, which leads to splanchnic vasodilation. So for the trainees, all of you know this, the cirrhotic patients who come to us, they typically have low blood pressures. This is because of nitric oxide, and you have increased portal blood flow. into a fixed, scarred liver. And this leads to all of the complications that we see, including the variceal bleeding, ascites, bacterial translocation. And so again, here is our portal vein. Here is this distorted sinusoidal architecture. And so the blood flow is going in. You have vasodilation, and the blood backs up into the spleen, into the here along the the gastric veins here, and you wind up with esophageal varices or gastric varices that can again rupture. And we've already had a nice talk today about the physics involved here with why these varices increase in size. So typically varices in the setting of cirrhosis, they increase and can progress at a rate of 7 to 8% per year. So here's a beautiful esophagus here. These are small varices here, and then here are large varices with endoscopic red signs. And when you do a screening endoscopy, which I'm sure everyone in this room has done now, you will see these red signs here, and these red signs are actually dilated nutrient vessels of the variceal wall. So that is, the portal hypertension is so severe, not only do you get a large varix, but also the nutrient vessels that supply the varix wall are also dilated. And this is a harbinger that these varices are at high risk to rupture. This was a question, so when you do the quiz, all of you should get this right. You need a hepatic vein pressure gradient greater than 12 millimeters is necessary for rupture. Not everybody who has a gradient greater than 12 millimeters ruptures, but again, if you are bleeding, your hepatic vein pressure gradient is greater than 12 millimeters. And we target this also when we do TIPS, or when we refer our patients for TIPS. Radiologists try and get the hepatic vein pressure gradient to less than 12. So now let's talk about some of the varices that we see and what happens when you don't control the bleeding right away. So the majority of variceal bleeds are esophageal, and this is 90% of the esophageal variceal or the variceal bleeds. And again, typically the larger the varix, that's not surprising, the more advanced the cirrhosis. This is something that is very common, and when I was rounding the other day here, I was impressed on how many so many people here present with relatively advanced liver disease, and again, child Cherkov-Pugh C-score certainly are at higher risk for bleeding. Those with the endoscopic red signs, these are the cherry red or the red whale markings. The hepatic vein pressure gradient needs to be greater than 12 millimeters, and the reported mortality rate is 20%. So again, this was a case that I had several years ago, but it was very interesting because it was actually two different varices that were bleeding, came down here. You can see we had one vessel bleeding here. We ligated it and wondered why the field wasn't clearing. Pulled up more proximately and found out we had driven by another varix that was bleeding briskly. And so you can control these typically with variceal ligation. Here is a large bleeding gastric varix. We're retroflexed here in the cardia. And all of you who have seen these gastric varices know that these gastric varices become quite intimidating in their size. And again, we'll talk a little bit about how we treat these, but it's typically, in the US at least initially, we use a little bit more sclerotherapy than cyanoacrylate, just because it's a bit harder for us to get cyanoacrylate readily, but both are appropriate first-line therapies when you're trying to stop a gastric varix that is bleeding. So, band ligation. This has actually been a remarkable advance. We have many senior hepatologists here who can tell you all the unpleasant experiences with sclerotherapy that we used to have. I mean, these patients got bacteremic, they had these horrible esophageal strictures, and you would sometimes get these horrible portal vein thromboses with sclerotherapy if you used enough of it. And ligation is much easier. There are multiple band ligators. You can control the bleeding 90-95% of the time. And that in combination with a splanchnic vasoconstrictor, in the US we use octreotide or sandostatin. Here you can use somatostatin or terlipressin to try and divert blood away from the esophageal varices. You do this for 3 to 5 days. along with antibiotics to prevent bacteremia, which is very important. You have to remember to do that. We have had patients who come in with variceal bleeds who are listed for transplant who have managed to not get their transplant because they developed endocarditis because nobody put them on an antibiotic initially, and they would seed their valves. So that's very important. And the other thing in any variceal bleed, to make sure it doesn't become complex, is to make sure that the hemoglobin stays around 7 grams to 8 grams per deciliter. Typically, when these patients are on gastrointestinal units, this is not an issue whatsoever because the GI group are very experienced in taking care of these. In the U.S., we have hospitalist service now where we have internists, some of whom are excellent. Others may not have as much experience, and if they keep transfusing them, get the hemoglobin higher, you can wind up with repeated variceal bleeding. So an ideal hemoglobin is 7 to 8 grams per deciliter, and this literature evolved maybe now 15 years ago, because we used to maintain their hemoglobins quite a bit higher, but really this does minimize any of the bleeding complications. And so this is how we ligate, and then of course sometimes you go in and you ligate the varix, and then you think everything is fine. You get a call maybe 6-12 hours, maybe the next day. The patient is having recurrent hematemesis and has had another hemoglobin drop. And typically, these bleeding complications are from these so-called banding ulcers. If you call the next day, the band is likely fallen off, which is always something that's unpleasant. But you go down, and you can see here the band has fallen off here. It's bleeding. You can also see down here there may be some banding ulcer down here as well. These are a little bit harder to manage. My own preference is to try to religate these. I think once you start injecting things into the esophagus, I think any future therapy just gets more challenging. But I like to try and band, but that's not always feasible. We certainly use cyanoacrylate or sclerotherapy when we can't stop the bleeding. Depending on the location of the varix, I don't know if you have access here to endoscopic clips, but those can actually be quite accessible. Some of these vessels can be quite accessible to an endoscopic clip, particularly if you can't get good suction and bring the varix up. Of course, some are just oozing slightly, and it takes a seasoned endoscopist to know when not to touch something. Because you're sitting there, you have this varix, it may be oozing slightly, but if it looks like they're stable, sometimes the safest thing to do is just to continue your supportive care, your somatostatin, your terlipressin, just get out and the bleeding stops, hopefully, and subsides, and you can take credit for that. And you do that without having to go in again and try and treat a major varix or make things worse. Finally, sometimes you go in and the bleeding is just substantial, and you have to place Senstaken Blakemore tube. Do you train your fellows here on how to put these tubes in? So we have Senstaken Blakemore, you have Minnesota tube, there's a Linton Nachlas tube as well, it doesn't have esophageal balloon on it. But these tubes all have the same strategy, which is that you have a gastric balloon, can be anywhere from 240 to 400 mLs, that you blow up once you make sure it's safely in the stomach, and you hook this up to your Senstaken Blakemore tube. You use usually a liter bag of normal saline as traction, and and you bring this up here and you try and compress around the cardia here. And this typically stops the variceal bleeding. However, for some complicated esophageal variceal bleeds, you have to inflate the esophageal balloon as well. And we typically don't have to do that, but sometimes you do. And the reason you have to be a bit more careful when inflating the esophageal balloon is because the esophagus lacks a unique layer. And this was going to be one of my test questions, but not going to say it. The esophagus lacks a serosa, or a serosal layer. So therefore, if you blow up the esophageal balloon and you keep it blown up without deflating it, you will get ischemic necrosis of the esophagus. And that's never a good thing. And so you have to deflate the balloon typically every 30 minutes, every 6 to 8 hours. And we attach the esophageal balloon to a sphygmomanometer, and we blow up the esophageal balloon to about 35, 40 millimeters of mercury. That seems to be enough to give at least more than 12 millimeters of radial force out, which is enough to tamponade or compress any bleeding esophageal varix. And we can leave it up for 1 to 2 days. That buys you enough time to either have a salvage therapy or hopefully get coagulopathy, et cetera, corrected. Just as a side note, make sure that when you're putting this in, that you measure during your endoscopy exactly where the GE junction is, so that when you're blowing up the balloon, you make absolutely certain you're blowing it up in the stomach. This is a very famous chest x-ray from the New England Journal of Medicine, where some poor unlucky individual here had a Senstaken Blakemore put down, but they blew it up in the esophagus and not in the stomach. And you can obviously see, all of you, we're not pulmonologists or radiologists, but we can all see here that clearly on the left lung field there's something that doesn't belong there. That is a balloon, and this unfortunate person developed Boerhaave syndrome and did not make it. So make absolutely certain your landmarks when you're putting these down that you are in the esophagus. Beta blockers are good. We heard a wonderful talk, so I don't have to go into that at all. What about bleeding gastric varices? Again, sclerotherapy or cyanoacrylate, but it depends on local expertise as well. And so, like I said, we've occasionally clipped these if it's favorable. If you can't control the bleeding, though, they typically need a TIPS or balloon-occluded retrograde transvenous obliteration, BRTO, which we'll go over. And these are for your GOV1 gastric varices or your GOV2, which are extend over here toward the fundus. And so it's important. Sometimes the radiologists like to embolize these when they do a TIPS. That's why we like BRTO better, because there's nothing more annoying than trying to look at CT scans where somebody's put embolization coils into the stomach, because you can't see the left lobe of the liver, and it's usually what happens is, luck would have it, they have a mass in the left lobe of the liver, and you have this huge artifact there trying to interfere, and so it's difficult. So we tend to like BRTOs if possible with gastric variceal bleeding. And again, tips for recurrent variceal hemorrhage. Second variceal hemorrhage bleed with esophageal varices. First for gastric varices is typically the standard of care. And again, they can embolize them, but again, we ask them to try not to do that if possible, simply because we want to preserve our imaging of the liver. And of course, you can get encephalopathy. Here's the BRTO, and so again, to do a successful balloon-occluded retrograde transvenous obliteration, we heard about this, but the important thing is you have to have some type of splenorenal shunt to access this. And so most of the radiologists, most of the time with gastric varices, you have this. This is in panel A over here, but you need that to be able to get up into the gastric varix so that you can release your sclerosant and blow up your balloon here and cut off all of the collaterals here. And this typically is quite successful. And again, lower rates of encephalopathy. What about other types of varices here? Bleeding ectopic varices. So here we have a stromal varix. This is somebody who has had a colectomy. And so this is the colon here. You can either ligate these. Sometimes we put a TIPS in. Sometimes you can sclerose them. Large rectal varices, we typically also put in a TIPS. You can actually ligate rectal varices as well if need be. While not variceal bleeding, sometimes you have hematemesis, and it's either due to portal hypertensive gastropathy or GAVE. So just remember that a TIPS works for GAVE. It doesn't work for gastric antrovenular ectasia. Gastric antrovenular ectasia or watermelon stomach, you can treat with argon plasma coagulation, and actually something that works pretty well also is band ligation for refractory gastric antrovenular ectasia, although what I have noticed is the patients really don't like it. I mean, they complain of a little chest pain with esophageal varices. If you start putting the bands down in the antrum of the stomach, they're really unhappy with you for a few days, although the bleeding typically stops. We do have to talk about mesenteric thromboses, because these do, particularly portal vein thrombosis, also cause variceal bleeding. These individuals can present with acute variceal bleeding if you image them. As you can see here on the bottom panel, you don't have a portal vein, and you know it's acute because there are no cavernoma here as well. Lots of different reasons to cause these, including thrombophilia, as well as various infections or local injury to the portal vein. And over time, and by time I mean just a few days, 10 days to 2 weeks, you can start getting this cavernous transformation of the portal vein. And I'm sure some of you have seen these in the report. These are the collaterals that go around. Can be quite dramatic and it leads to its own sets of complications. But again, when someone presents with a portal vein or an acute variceal bleed, and you image the liver and find, if you start seeing cavernoma, you know that that clot has been present for at least a few weeks. Just by way of clinical caveat as well, splenic vein thrombosis can cause pancreatic, or can be caused by disorders of the pancreas, and typically is. This means acute and chronic pancreatitis, as well as pancreatic pseudocysts, usually in the proximal portion of the splenic vein. You can see here in the left panel here that you have a thrombus here that's extending from the hilum of the spleen essentially all the way up the portal vein. And when you go down into the stomach here, you'll see these large serpiginous vessels here. These weren't bleeding, but sometimes the bleeding can be quite dramatic. And the treatment of choice for a splenic vein thrombosis is typically a splenectomy. If you have a portal vein or mesenteric thrombosis with injury to the gut, you have to anticoagulate. If they are bleeding, you need to ligate them first and make sure the varices are adequately treated. And we typically use low molecular weight heparin or transition them to warfarin, although in the absence of cirrhosis now, we're starting to use these novel anticoagulants. I don't know how much you use these here. They don't require monitoring, but if you bleed, the antidotes are actually a little bit problematic. And so we typically anticoagulate these individuals, though, and typically that's because most of our patients we're seeing, most are potential transplant candidates. It makes the job much easier for the surgeon. And so the important thing to know, though, is that if they're presenting with an acute complex variceal bleed, that you need to ligate the varices first before you initiate your anticoagulation regimen. So in summary, screen your appropriate patients for varices, and if they're presenting with hematemesis, typically you're going to band ligate esophageal varices with TIPS as a rescue therapy. You should have a first go at trying to obliterate varices in the stomach or gastric varices with cyanoacrylate or sclerotherapy, but make sure if you see large varices here that you have a great working relationship with your interventional radiologist. Regardless, you should beta block these individuals. If you have some mesenteric thrombosis that leads to an acute variceal bleed, anticoagulation is the mainstay of therapy, but you have to treat the variceal bleeding first. We won't talk much about closing portosystemic shunts, although that's also an option if they get encephalopathic. I'll stop here, and again, thanks so much for the invitation and spending some time with you.
Thank you, Dr. Pal, for this wonderful and comprehensive talk for our audience. And finally, we have the 4 questions. And I see the Professor Pal and Professor Gyasun Nabi Tayyib in the hall. I request you that you please mention your name and from whom you want to ask the question. We have the first question, that arterioportal shunts, where do you place it? Either in the pre-hepatic or the hepatic? Once again, I request that we have the 2 speakers in the hall, Professor Gyasun Nabi Tayyib and Dr. Pal. So please, anyone of you, we have the question that arterioportal shunts, where do you place it? Either pre-hepatic or hepatic?
If I may clarify my question, sorry, these were only notes and you asked me to send a chit in. So these were my notes for that. Anyway, I'm always confused. If we have a tumor which is causing portal hypertension because of invasion, and we know there's a huge arterioportal shunt along with it, and the ascites becomes or reaches a stage where it's intractable, where do you call it? First, how do you classify it? Is it a hepatic problem? Is it a pre or a post thing? 1. Number 2, what is the approach towards these patients? How do you sort them out with these huge shunts?
Well,
So the question is, you have someone who has a hepatocellular carcinoma and you have invasion. There's arterial portal shunting, variceal bleeding as well. And the question is, how do you manage these individuals? So that's a very difficult situation. Typically, the tumors by that point are very advanced. So you would go in endoscopically and you would try and control the variceal bleeding first. That would clearly be your first choice. Then you would call the interventional radiologist, and we would see what we can do about the shunt. Typically, the arterial portal shunts, they sometimes do contribute to the variceal bleed as well. It just depends. The CT scans are very helpful because you will actually see sometimes you can see which way the blood is flowing, and if it's going retrograde into the portal vein, that's a big problem because that's probably contributing to portal hypertension. We would probably ask them to try and embolize that and close it. But by the time you have a large tumor that's that size, it is very likely that there aren't going to be great treatment options for that person with regard to their hepatocellular carcinoma. Sometimes we ask our radiologists to do local regional therapy, embolize the tumor. But again, once it's invaded into the portal vein, really we stabilize the bleeding, and those individuals, if they have preserved hepatic function, get systemic therapy. That's going to typically be our approach.
Okay, Dr. Paul, we have another question for you. How to measure the portal pressure non-invasively?
How do we measure the portal
Pressure by non-invasive methods.
By non-invasive methods? So we actually have a very novel way to do this. And it is something we have just started doing. We use endoscopic ultrasound, and the company Cook actually makes a catheter now where you can directly puncture the portal vein, you directly puncture the hepatic vein, and you get measurements of both, and you can also get a liver biopsy. So there's no wedge pressures. And we're doing this rather than relying on just the standard going down through the jugular vein and just measuring free and wedged hepatic vein pressure measurements. So we actually can do direct portal pressure and direct hepatic vein. And that's what we've been doing. We have a EUS group here that's very interested in exploring this. And so that has been our method of measuring portal pressures. Otherwise, non-invasively, we don't have any other really great ways of doing this. Some people claim that splenic veins or splenic stiffness is another surrogate marker, but we have had limited success with that. Yeah. 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 Do you standardize it? One of the things that we have found is that there's huge variability amongst interventional radiologists, and sometimes the quality of the data you get varies day to day depending on which interventional radiologist is down in the suite, and so. Mhm. Yeah. Well, their clinical judgment is required, isn't it? So if you have a cirrhotic liver, if you have a nodular liver, et cetera, then measuring the hepatic vein pressure gradient may not be so important. However, once you've intervened, I think it becomes very important. So the biggest way, for instance, is when you do a TIPS, right, and the ascites doesn't resolve. And then we ask our interventional radiologist to go down and remeasure the portosystemic gradient as an example. But that's, again, that's invasive. The other ways, I think it's because of the relatively invasive nature of going in through the jugular vein. I think we just tend to stay away from it. But we do measure a fair number of hepatic vein pressure gradients in our practice as well. Although, again, we're evolving. We like direct portal pressure measurements as well, because sometimes what we have found is that when we thought, for instance, that our portal pressures were actually improved by measuring the hepatic vein pressure gradient, when we actually measured them directly, we still had substantial pressure differences that we hadn't accounted for.
Okay, so we have remaining the 5 minutes behind, and we have a lot of the questions for you, please, sir. And shortly and quickly, I'm asking that what is your policy for managing the bleeding varices and bleeding from the mid of esophagus, and varices in the lower esophagus are very minimal. What is your policy regarding this?
In the mid-esophagus?
Yes.
If they're bleeding?
Yes, bleeding.
Oh, yeah. Well, you have to ligate them, but they're going to complain when they come out, because as all of the fellows here know, the more distal you get, the less innervation of the esophagus. The higher you go, you get the striated muscle, it's more innervated. But typically, the higher you go toward the mid-esophagus, the less likely they are to bleed. Although, particularly if someone has been treated endoscopically, yeah, you do rupture occasionally, and you have to ligate them. But I assure you, in Pakistan, you probably don't have patient satisfaction scores. Is that right? Patients don't wake up and rate you like we have in the United States, because, boy, they're unpleasant when they wake up. Lots of chest discomfort. But if it's truly bleeding, you have to ligate it. It's not that common you have to.
Okay, sir.
Vessels coming from the esophagus and hemiesophagus veins. You bend them, the bands come off. They have a bleeding punctum, and every time you bend them, patient bleeds again in the next 24 hours. Do you have anything?
So I haven't had that experience, but if they keep bleeding despite your best efforts to ligate them.
Well, the moment we bend them, the band slips off. That's something which happens in the mid-esophagus. We bend them, and the band just comes off.
That's a very difficult problem. I would probably TIPS them then, if that's what's happening, and use that as my salvage therapy if you can't control the bleeding.
There is again another important question by Dr. Professor Lubna Komani. She said, what is the role and experience of failing the covered esophageal stents in the refractory bleeding?
So I don't place stents. So our therapeutic endoscopists have used stents to stop a variety of bleeding in the esophagus, and also, quite frankly, in the bile duct as well, and the bleeding there as well. We haven't done that. But in theory, I could see how through tamponade it could actually potentially work. So.
Okay, she's also asking for the role of hemospray in the post-bending ulcers.
Role of EUS.
Role of hemospray in the post-bending ulcers.
Yes, that by hemospray buys you 24 hours till your partner is on call, and then they'll have to deal with it. Okay, right? So you stop the bleeding, awesome, you go home. Okay, but then the next day somebody else will have to come in and contend with the bleed, right?
So last question is there, sir, by Dr. Shahid. That patient have the SMV thrombosis developing bleeding from the duodenal varices. What may be the best management approach?
Yeah, those are very difficult. Those are very difficult cases. And so what we typically do is we try and control the bleeding in the duodenum locally. And then with an SMV thrombosis, once we are satisfied that it's controlled, then we anticoagulate those individuals. There are not a lot of great options there when you have an SMV thrombosis, but generally they have to get and they have to be anticoagulated, and you try and locally control the bleeding. But I have to tell you, some of those are exceptionally difficult to control. We've even had our surgeons go in and actually go in and ligate these for lack of anything else. But this is typically an SMV thrombosis, not in the setting of advanced liver disease. Because once you get to cirrhosis, they don't want to touch.
Paul,
Thank you.
Do you advocate use of stenting or thrombolysis in SMV thrombosis for these symptomatic patients?
If the radiologist can get down there and
Oh yeah, getting down there is not the issue.
and reach.
Keeping it open after thrombolysis for another 72 hours is a big deal. So do you support that? That's what quite a few people do, advocate that you use thrombolysis, intravascular, intravenous, and then stent them.
In the now, so you've taken away the duodenal varix bleed now. Yeah, because I would not be doing okay. Yes, so now you're just talking SMV thrombosis alone, right? And you've gone down. Yeah, so then you can certainly do that. Again, you just have to make sure that the stent stays open.
I think I shall support your views for duodenal varices, tissue glue injection. And as regards the SMV thrombosis, one has to recanalize and place a stent and keep the person anticoagulated. But there's not many people who can recanalize the splenic vein or sphenomesenteric vein and stent over there. There's not many interventional radiologists. Do you know many?
No, I don't know. I don't do it, and I'm not a supporter of it. Because I know they lock up the bleeding 72 hours.
One of my colleagues does it and does it very happily.
Well, hopefully you won't be on call too. Right.
Okay, thank you all. Thanks to all of you. And now for the final comments, I hand over the mic to Professor Mohammad Arif Nadeem Saab.
Professor Paul, can I ask you one question? Have you any experience of doing APC on duodenal varix?
APC?
Yeah.
No, never done that.
Okay, and the end, we are obliged
Have you had good luck with that?
I thought it could work.
They're just so uncommon. That I mean, the few ones we've had though, all of these large bleeding duodenal varices are they're exceptionally challenging.
Okay, we are obliged that the Pakistan Society of Hepatology have honored us to be chairperson of this session. Very wonderful, knowledgeable sessions in which we have got two excellent talks from basics to treatment from Professor Javed Farooqi on portal hypertension and from Professor Ghayasul Nabitaya for non-cirrhotic portal hypertension. And we learned another thing to include in the examination of our GI tract, that we have to have focused ultrasound in our pocket to do the ultrasound at the bedside. Similarly, as we have already included in our examination armamentarium the X-ray in the examination of chest. So I think it is very wonderful thing to have it, to do the bedside evaluation for portal hypertension. Thankful to Professor Nadeem Tihami who have added this thing. At the last, the Professor Paul have advised us on the treatment of the complicated upper GI bleeding. Thank you very much. Thank you for organizing committee for selecting these wonderful topic in this session. Thank you very much.
Thank you very much, sir. With this, we are going to end up the session, and for the pediatric hepatology, I hand over the stage to my colleague, Dr. Arit Prakash.